We are live. So we are live.
Yeah. प्रेसिडेंट सर आपको शुरू करना है.
Good evening, everybody, and welcome to this ORTS webinar today. Today, we have a very interesting topic on ophthalmic pathology related to ocular oncology. Today, we have a great speaker, Dr. Mulle.
Kaustubh
Mulle, and it will be moderated by Dr. Dipankar Das. And I welcome the panelists and the discussions and anticipating a very interesting session. Thank you.
My screen visible?
Yeah. Yes.
Thank you, President Ji. So, Dr. Devashish is busy with some other program. So, I welcome you all once again to our EIZOC ORTS program 33 number series. And today, as our President already declared, this is a really beautiful new subject. I would say it's a new subject, and by none other than our Dr. Kaustubh Mulle, young dynamic pathologist, I would say. So this subject is definitely very interesting for all of us and all the postgraduates. So I'd be happy if the postgraduates interact with the speaker in this program. This is our team, and I really thank our EIZOC team, President of EIZOC, Secretary EIZOC, and Chairman Scientific Committee, Dr. Nitin Dera, to support this program regularly every fortnight. And of course, the credit goes to our mentor, Dr. Ajit Babu Maji, selecting the topics, selecting the speakers. Definitely today is a really very good topic and very good speaker too. So I am the coordinator. With me, Dr. Sabishas Patnaik, my co-coordinator. We coordinate this program since last few years. So today's speaker, Dr. Kaustubh Mulle, and I will request our moderator to introduce him to the audience. So I will not speak much about him. And today's moderator is Dr. Dipankar Das. He is from Sri Sankardev Natralaya, Guwahati, Assam. He is a senior consultant and HOD. And today's panelists, there are Dr. Samishta Behra, Professor Bimsar Bugla, Odisha, and Dr. Kalpita Das, consultant, bit retina and ocular oncology. Kamal Narayan, Maja Sankardev Rajarat, Calcutta. Dr. Vibhuti Kashyap, Deputy Director Kashyap Memorial Hospital, Jharkhand, and Dr. Salabh Sinha, ophthalmologist, Raj Retina and Eye Care Center, Patna, and of course, Dr. Devjot Tripathi from consultant from Bhubaneswar, LBA Bhubaneswar. So these are our postgraduate students who will be participating in this program. Dr. Smruti and Dr. Pragya from Nimsar Burla, Dr. Priyanka and Dr. Renuka from AIMS Patna, Dr. Alok Ranjan and Dr. Sadaf Kadri from MKG Medical College, Berhampur, from my hometown, and Dr. Satrupa Das from RIO Kolkata, Trasis and Priya from Bhagalpur Medical College, and Devjit Daka, Silchar Medical College. I request all the postgraduate students to stay with the video on and interact with the speakers and panelists with these few words. Once again, I welcome you all. I'm sorry, my throat is very bad. So thank you very much for joining this today's program. Now it is over to Dr. Ajit Babu with the few words.
Yeah, thank you, BNR and Dr. Jayanta. This is, I particularly wanted it so that the basic pathology, especially related to ocular oncology, is very, very essential for all the postgraduate trainees, because in the exam, most of the weak aspect of any students is pathology. And Kaustubh is very well versed with all the ocular oncology specimens, and I worked with him for quite some time, and we know each other. And I know his strengths, so I chosen him as a speaker. And I told him that he should interact with the postgraduates well, so that they can imbibe the subject better, so that it will be useful for them, not only for the exam, but for future also.
Thank you.
Yeah.
Dr. Nitin, your comments?
Dr. Nitin Dira. Unmute.
Chairman,
Yes, sir. So we all know that this is definitely very essential subject, and learning oncology without cytology or the histopathology is, not making any sense, because anyway, knowing the tumor and the behavior of the tumor is always being accompanied or acquainted with a good cytopathology that we all know as a clinician. But from exam point of view, from resident point of view, as sir was saying, that's definitely very, very important. And most of the time, this is being seen that they are weak in this area. So from all point of view, this is important for everyone. Keeping in mind, sir has designed it, Dr. Ajit Babu Majji, for the residents way. And I'm sure that Dr. Kaustubh Mule will keep it in that way, that all the residents will definitely be benefited. Thank you again to have.
Thank you, Dr. Nitin. Now it's over to Dr. Dipankar Das, our moderator for this today's evening. And
good evening.
Please.
Thank you, sir. Good evening, everybody. Mentor Ajit Babu, sir, President, sir, BNR, sir, everybody, the panelists and the students. It's my pleasure to introduce Dr. Kaustubh Murle, who did his basic medical education from KIM's Karad. He received his postgraduate training in pathology, followed by senior residency in anatomical pathology and cytology from Apollo Hospital, Hyderabad. He further got trained in oncopathology in Bangalore Institute of Oncology and ophthalmic pathology from LB Prasad Eye Institute. He currently heads the National Reporting Center for Ophthalmic Pathology at Center for Sight, Super Specialty Eye Hospital, Hyderabad. He has 92 peer-reviewed publications and as many as presentation to his credit in national and international forum. He got major awards such as Dr. Gangadhar Sundar Award from OPI and he SC Doctor Award from AIOS, then from SN Cooper Award from Moscone, and Subbalakshmi Gold Medal from IAPM. Beyond his academics, his interest is in the fitness enthusiast, and he is a triathlete, taken part in various what you call Ironman event and in Asia, Europe, and Australia. In addition, he is certified rehab and strength conditioning coach, a certified functional range conditioning mobility expert, and certified LBA1 animal flow instructor. With this brief introduction of this accomplished pathologist of our country, I invite Dr. Mule to present his lecture on ophthalmic pathology in relation to ocular oncology. Dr. Mule.
Thank you, Dr. Dipankar, for such a wonderful introduction.
Thank you.
And thank you, EIZOC. Thank you, Dr. AB sir. Thank you, Dr. BNR sir. And thank you, Dr. Nitin, for such a for your kind words. Okay. Before we get started, I would request all the discussants to please turn on their videos. I can see Dr. Pragyan Bharti, Dr. Priyanka, Dr. Renuka, Dr. Alok, Dr. Ashish. I think I can see you all, but please switch on your cameras. Okay. Now, ophthalmic pathology, it's an important aspect of oncology, and it forms the backbone of ocular oncology. Pathology, ophthalmic pathology started many decades ago with the description of the gross anatomy of the human eye. Then with the discovery of the ophthalmoscope and advances in histotechniques, clinical correlation evolved, and so did ophthalmic pathology.
Also,
From
you need
what?
to make full screen.
It's not full screen?
It is not full screen.
Okay, 1 second. I'm just going to. Is this better?
This is better.
Yeah, this is, I think.
Okay, right. So pathologists are now at the center stage of multidisciplinary meetings, providing vital information on the not just diagnosis and prognosis, but they sometimes also guide therapy in patients with ocular tumors. From what used to be a subject of special interest for someone, and with the pathologist looking into glass slides, appreciating the pink and blue colors, it is now a very big discipline that incorporates modern tools such as molecular biology. And with the use, awareness, and application of molecular biology, pathologists are taking cancer care and close to precision medicine now. But however, for this to happen, it has to be a very good teamwork between the ophthalmologist and the pathologist. So, when is it that you people need me? Me in the sense, pathologists. When is it that you need me? Well, the list is very exhaustive. Rather, I would tell you when it is okay to bench me. So, any patient who has less than 40 years of age who presents with a chalazion and you decide to curate it, it's okay if you don't send it to the pathology laboratory. Skin removed during blepharoplasty or any other cosmetic procedures, normal tissue removed during ectropion or entropion surgeries, or fat excised in a case of fat prolapse. All these are tissues which you can choose not to send it to the lab only in conditions where you feel that the patient cannot afford it or a pathology examination is not viable. Ideally, every tissue that is excised from the human body has to be sent to the lab. Now, when we are talking about specimen and histopathology, the journey of the specimen occurs in 3 stages: pre-analytical, analytical, and post-analytical. Now, pre-analytical phase includes communications between a pathologist and ophthalmologist, the surgery itself, a proper documentation which includes a proper filling of the request form, packaging and transportation of the specimen. The analytical phase happens in the laboratory where we gross the specimens, we process them, sections are made, and then finally we view the slides under the microscope to come up with a diagnosis. The post-analytical report includes nothing but the report, any supplementary reports in the form of special stains or multidisciplinary meetings. Now you would ask me, when is it that an ophthalmologist needs to speak to a pathologist? Well, there are several cases or several situations. Let's just say a case of lid tumor where an excision was already done, a reconstruction was done, the patient presents with a recurrence. Now, you do not have enough scope to take out a lot of tissue. So you need to call up the pathologist, discuss with him that, देखो ये margin, it's very close to the tumor. I want you to look at it properly. I don't have scope to go beyond over here. Or there might be situations where you would want certain tests which demand special fixators. We'll go through that list later. Or there can be special tumors where special stains are needed. For example, sebaceous carcinoma. Sebaceous carcinoma demands the need of a oil redo stain. For an oil redo stain to be done, you should not be sending the tissue in formalin. It should be sent fresh. So it is important for you to discuss with the pathologist everything about the patient before you even decide to operate. After that, what is pivotal is filling of a request form, a duly filled request form. Now, when I say duly filled, what does it include? It obviously has to include the patient's demographic details, It has to include the clinician details, name, email, phone number. Why? Because if we have certain difficulties, we would like to call you up. Then the date of the surgery, nature of the specimen. I remember, why is this nature of the specimen important? Whether it's an incisional biopsy or excision biopsy. In an excision biopsy, we need to comment on the margins, whereas in an incision biopsy, we do not comment on margins of the tumor. Then location of the tumor or clinical information. I remember there was this, a very good friend of mine, a clinician, who once sent me a FNAC, and he just said specimen for cytology. That's all that was written, and all I could see was lymphoid cells, and I was contemplating a diagnosis of a lymphoma. And then I called him, कि देखो ये lymphoma लग रहा है, can you just tell me something more about it? Later on, I come to know that he has performed the FNAC from a preauricular lymph node. So we can go wrong if we do not have adequate information. Then, if there is any previous surgery performed, previous excision performed, or if there's a previous histopathology report available, please provide us with that information. Fine. Now you have filled up the form. You have taken out the tissue. How do you send it to the lab? Anyone wants to answer? How do you send it to the lab? What is the preservative that we use? Dr. Pragya, would you want to answer?
By using formalin.
Very good. By using formalin. Do you have any idea as to what percentage of formalin we use?
No idea, sir. I don't know.
Okay, so we use 10% neutral buffered formalin. All these, what do you say, parts of that statement are very important. Neutral 10% buffered formalin. Neutral means the pH has to be 7. Buffered means we add some chemicals to it so that there's no crystallization to it. And 10%. Now, commercially available formalin is 40%. We need to dilute it to 10%. Now, what we do is we place the tissue in a container, which can be either a plastic container or a polythene bag, and we add 10% neutral buffer formalin to it. We usually add the volume of the preservative should ideally be 10 to 20 times the volume of the specimen. But in specimens like enucleation, especially exenteration, it is not possible to have 20 times the volume. So in such cases, 4 to 5 times the volume of the specimen is sufficient. Now, if the biopsy of the tissue has been removed from different sites, like say superficial, deeper, then they should all be sent separately in separate containers and labeled, like I have shown in this picture. This one. Okay. Now, have you all heard of map biopsy? So this is the map biopsy. Now, in a map biopsy, we remove the small tissues from different parts of the ocular surface. This is usually done in a patient with a sebaceous carcinoma. So, when you send a map biopsy, ideally you should send each sample separately, or you draw a diagram on a filter paper and then place the specimen on it and then send it to the lab. If you are sending an excision biopsy and you want margins, make sure that you orient the specimen properly and label the margins separately. Now, for specimens excised for ocular surface neoplasm or OSSN, this is how you should send it. You draw a diagram on a filter paper, make sure that you have labeled the sites properly, place the tissue on it, allow the specimen to dry so that there's no rolling over of margins. Once the specimen is dry, then you pick it up, put it in a polythene bag that contains formalin, and then you transport it to the lab. Alternatively, you can also send the margins separately, like Dr. Santosh has done over here. He has sent the margins separately. It makes our job easier. Okay, now coming to the fixators. Like I said, for light microscopy and immunohistochemistry, 10% neutral buffered formalin is the fixative of choice. Normally bone marrow aspiration is performed by the pathologist, but if the pathologist is not available at your place and you want to do it, then ideally you should put that aspirate into EDTA or Helix fluid and then send it to the lab. If you want electron microscopy, then glutaraldehyde is the fixative of choice. If you perform a vitreous biopsy or you have a cassette fluid, then add 90% isopropyl alcohol to it in a ratio of 1:5. If you're not working in a multidisciplinary hospital, you have your own clinic, you decide to perform a FNAC, then ideally you should have at least 2 slides, one of which should be air dried, the other one should be immersed in 95% isopropyl alcohol and sent it to the pathologist. If you're transporting the specimen to a lab which is outstation, that means, let's say you are working in a rural place or you want to send it to a multi-speciality lab, then you should pack the specimen appropriately and transport it conforming to the UN 3373 guidelines. Okay. Now, if you need to do a frozen section, can anyone tell me why do you do a frozen section? Anyone of you? Just jump in.
Why in intra condition we need to confirm whether it is malignancy in tau.
Very good, correct. So intraoperatively, you would want to know whether this lesion is malignant or benign. That's the most common reason why we do a frozen section. There are other reasons why we do a frozen section. You want to assess the margins. Then there are certain conditions where you can alter the management intraoperatively. For example, in a patient with eosinophilic granuloma, you can give steroids intraoperatively. Then there are certain cases where you would want to know the adequacy of the tissue. So all these are situations where you would want to know a diagnosis as early as possible. It is called rapid intraoperative diagnosis. So when you want to send the specimen for a frozen section, you should send it fresh. Do not add any preservative. Just place it in a bowl, dip a gauze piece in saline, cover the specimen with that saline soaked gauze piece and transport it to the lab as early as possible, preferably within 10 to 15 minutes. If your lab is a little far away, make sure that you transport it in ice pack. Okay, now I have noticed this a lot of times. The physician or his fellows or his PGs start calling the pathologist even before the tissue has reached the lab. When will the report be ready? So know this. Routine samples take about 3 to 5 days. Frozen section takes about 15 to 20 minutes. Small biopsies usually take about 24 to 48 hours. Immunohistochemistry, if need to be done, it will happen in about 5 to 7 days. But if you are really pally with your pathologist, you can expedite all these processes. This is a trick. Okay, so to summarize, ensure all specimens are sent to the lab. Preservative of choice in most cases is 10% neutral buffered formalin. Ensure that you pack the tissue properly, label it, and transport it to the lab as early as possible. Don't hesitate. Rather, I recommend communicate with the pathologist, furnish adequate details so that you get a proper report. Okay, now we are going to go to some of the most common tumors that you encounter. But before that, I recently was chatting with my daughter. So she told me, I want to go to this place which has all of these. So if she has to go to this place, can any one of you tell me which country would she be going?
UK, sir.
Yes,
UK.
very good. What is this?
Sir, it's the last photo is a 934th platform.
Very good. So
Harry Potter, sir.
Harry Potter. Yes.
Harry Potter.
Yes, very good. Hogwarts. Yes.
Yes, sir, Hogwarts.
Okay. Okay, so this is not in any order of frequency. I've just chosen 4 tumors in a random order. So the commonest tumors. So let's look at this old lady who presented with this eyelid tumor. I don't think I need to ask you the diagnosis. It's a very straightforward diagnosis. Anyone? Okay. Neoplastic, non-neoplastic?
You ask by name.
So it has to be neoplastic. No?
Kaustubh, ask by name. They will answer.
Okay.
Sir, neoplastic.
Dr. Alok, you want to answer? Dr. Alok has switched off the camera and disappeared. Anyone else? Dr. Priyanka? Dr. Ashish? No. Okay, only Dr. Pragya is here. Okay, Dr. Pragya, please tell. Go ahead. Dr. Renuka is also. Yes. Tell me.
Sir, neoplastic.
Neoplastic, non-neoplastic?
Neoplastic.
Very good. Why neoplastic?
The surface looks irregular, loss of eyelashes.
Okay. Very good.
And
okay, fine. Okay, so what are the possibilities? Benign or malignant?
Malignant.
Okay, very good. So which are the malignant tumors of the eyelid?
Basal cell carcinoma, sebaceous cell carcinoma, and squamous.
Okay, so which of this is the most likely possibility?
Sebaceous cell carcinoma.
Very good. Bang on. Bullseye. Okay, so this is how a sebaceous carcinoma looks under the microscope. You have lobules of tumor cell. This central pink thing that you see over here, that's the comedonecrosis, right? And then you have this blue thing which you see, that's the tumor. Under high magnification, the tumor cells look very empty, signet ring-like, or they have a clear to vacuolated cytoplasm. That's because they contain lipid, and when we process these tissues, the tissues pass through alcohol, and alcohol dissolves the fat, so they appear empty under the microscope. Now, when you have a case of sebaceous carcinoma and a pathologist issues you a report, what do you look for? The report should contain the size of the tumor. It's going to change your TNM staging. Then you need to know the location, whether it's arising from the glands of Zeiss or meibomian glands. The grade of the tumor, whether it's moderately differentiated, poorly differentiated, presence or absence of vascular invasion or perineural invasion, because they are prognostic factors. Then status of resected margins. If the resected margins are positive, you'd probably know that the tumor might recur. You might want to go back and then do some wider excision. The last but not the least, and very important, is the presence or absence of pagetoid spread. Any idea what pagetoid spread is?
Subepithelial spread of tumor cells.
Okay, so it is not subepithelial, it is the epithelial spread of tumor. Now let's look at this picture over here. Can you see the epithelium over here? This one? This is all the epithelium, right? And you have this tumor getting into the epithelium. So this is how a pagetoid spread looks like. Now, when a pathologist sees pagetoid spread in a sebaceous carcinoma, he usually tries to mention whether it is above or away from the tumor. It is the pagetoid spread which is away from the tumor that is prognostically important. When you see a pagetoid spread, the clinician usually goes ahead and does a map biopsy because he wants to ensure if the rest of the ocular surface is clear. Fine, let's look at the next commonest tumor. Elderly gentleman with the ocular surface mass.
OSSM.
Straightforward diagnosis. Anyone? Dr. Pragya?
OSSM.
OSSM. Very good. Now tell me, what is OSSM? No, don't tell me the expansion ocular surface squamous neoplasia. Tell me what it is. What is it? Okay, OSSM is basically a spectrum of lesions which ranges from mild dysplasia to carcinoma in situ and invasive carcinoma. So based on the thickness of the epithelium that is involved, you categorize it as mild, moderate, and severe. And then the full thickness one is called carcinoma in situ. If it breaks the basement membrane and gets into the stroma, it is called a squamous cell carcinoma. Right? Okay. Now, when it becomes a squamous cell carcinoma, it is very important that the pathologist comments on two types of squamous cell carcinoma, a spindle cell variant and a mucoepidermoid variant, which is now called the adenosquamous carcinoma. It is important to mention these two variants because these are prognostically poor. They tend to recur as compared to the classical squamous cell carcinoma. Now let's look at this elderly gentleman who had this ocular surface tumor with orbital extension. Now this was the specimen that I received. I'm going to show you a cut surface also. Can any one of you tell me what specimen this is? What is this specimen? Don't tell me the diagnosis. Tell me what the specimen is. Have you ever heard of it? Yes, very good. It's an exentration specimen. So you have the eyelids over here, then you have the orbital tissue over here, and that's the eyeball. Right? So this is the exentration specimen, and this white thing that you see over here, that's the tumor. Okay. Now, when you send a sample of OSSN to a pathologist, this is what he is supposed to comment on. Very important. In a biopsy, excision biopsy, he should comment on the margins, right? And then he should comment on the base if it is an invasive squamous cell carcinoma. Now, when there's a comment on the base, it is also important to comment whether the base is involved on the corneal aspect or the conjunctival aspect, because involvement of the conjunctival base is what is important for the clinician. If it is an exentration specimen, two prognostic factors of importance are intraocular extension and involvement of the soft tissue or resected lid margins. Okay, let's get on to the third commonest straightforward diagnosis. What is it?
Retinoblastomas.
Very good, retinoblastoma. Okay, now this is how an eyeball is sent to us. And this is a very typical, I mean, we do not any longer get such eyeballs because these days there's chemoreduction, there's plaque brachytherapy, all the eyeballs are distorted and come to us. But this used to happen when primary enucleations were performed. Okay, can any one of you tell me that if an eyeball is sent to the lab, which part of the eyeball does the pathologist sample first?
Optic nerves.
Optic nerve.
Very good. Not just optic nerve, the resected end of optic nerve, right? This is what the resected end of optic nerve is. And this is how we sample it. Now, once we sample the resected end of optic nerve, then we go ahead and cut the eyeball. Now, how we cut the eyeball depends on the location of the tumor. Now, in an intact eyeball like this, how do we know where the tumor is? Any idea?
By sentinel vessels.
No.
By staining.
What is this? What is this? What is this structure?
Vortex vein, sir.
No, this is not related to the question I just asked. Yes, vortex. Very good. Okay. What is this?
Transillumination test.
What test is this?
Transillumination test.
Transillumination test. Correct. Now the picture on your left top, you see that the eyeball is appearing red. This is how it should normally look because of the vasculature. Whereas the picture on your bottom right, at the top, can you see a black shadow? So a tumor will give you a black shadow. That's how we know where the tumor is. When you cut the eyeball, this is how retinoblastoma looks to a naked eye, which has a fish flesh appearance characteristic. Microscopically, it's a very blue tumor, which is composed of typical rosettes. These are the two rosettes you see in retinoblastoma.
Flexner ventostina rosettes and homerite rosettes.
Very good. That's it. Now, no clinician would send the eyeball to the pathologist for, yes, sir.
The cell types and how to identify each cell types also in each tumor, probably you need to highlight.
Okay, fine. I will do this.
Yeah, thank you.
In humor, there is central, it's not hollow.
No clinician would send the eyeball to the lab to make a diagnosis. You probably already know the diagnosis even before you have enucleated. So why do you send it to the lab? Because you want to know histopathological high-risk factors. Now, which are the histopathological high-risk factors? Does anyone want to tell me?
Spindle cells.
Sorry?
Spindle cell is risk factor.
No.
High risk on a macroscopic.
NC ratio. Sir, NC ratio.
See, what you are telling me is something that is very generic to all tumors, but I'm asking something very specific to a retinoblastoma. So there are few features or observations that are labeled as high-risk factors, which mean that if you find these factors, the management will change. The first among them is massive choroidal invasion. Now, any choroidal invasion that is equal to or more than 3 millimeters is massive choroidal invasion. The second is retrolaminar optic nerve spread. That means spread of the tumor beyond the lamina cribrosa. The third one is extraocular tumor spread. The tumor goes beyond the sclera into the periocular soft tissue. The fourth one is involvement of the anterior segment. And the last one is scleral involvement. We'll look into this a little more detail. Let's look at this picture. What do you see over here? Can you see this?
Angle.
What is this? What part of the eye is this?
There's a limbus.
Angle, no?
Angle, yes. It is the angle. So you have the iris, you have the ciliary body and the angle over there. Let's look at the cut section of the eyeball. This is the lens, right? And you have this tumor sitting over here. You see the white thing? That's the tumor sitting over here. So this is involvement of the anterior segment by the tumor. And this is how it would look under the microscope. Do you identify these ciliary processes? These are ciliary processes. You have the anterior chamber over here. This is the iris. This is the cornea. And you have this all blue thing that you see over here. That's the tumor. So this is involvement of the anterior segment. Let's look at this picture. This is the cut section of the eyeball. This is the tumor. Right? Anything in particular you notice? Can you identify the choroid? Yes, very good. The tumor is involving the choroid. And this is how it would look under the microscope. So like I said, if the choroid is involved up to or more than 3 millimeters, it becomes massive choroidal invasion. Even if you see multiple foci of involvement, all of them are less than 3 millimeters, but together they amount to more than 3 millimeters or equal to 3 millimeters, it still becomes massive choroidal invasion. Okay, let's look at this. What do you see over here?
Intravitreal.
What is this? Giving you a hint.
Optic nerve.
Yes, optic nerve. So in this picture, can you see there's this tumor and here's the thickened optic nerve. Now, when you look under the microscope, normally this is how an optic nerve should look like. You know, this is the optic nerve here, this part. Now, if you want to locate lamina cribrosa, this is the sclera. Right? This is the sclera. Now, if you draw an arbitrary line from one end of the sclera to the other, that's usually where your lamina cribrosa lies. Now, if you look over here, that's the tumor. Okay? And this is the optic nerve. This is the optic nerve. Now, look at the next picture. You see, the tumor is going through the head, through the lamina cribrosa, into the retrolaminar optic nerve. So that becomes your high risk factor. Now, this is the resected end of the optic nerve, which was positive. Now, if you look at this picture, it is the parenchyma of the optic nerve, which is positive. Whereas if you look over here, the tumor is around the optic nerve. That means it is along the meninges. In both cases, it becomes a T4 tumor. Okay. Now, this pink thing over that you see is the sclera, and the blue thing is the tumor. You see this tumor getting into the sclera. So that is scleral invasion. In this case, you have the sclera over here, and you have tumor on both sides of the sclera. And you see the tumor is going into the sclera. So if I take multiple sections over here, I can possibly demonstrate the full thickness scleral invasion. So this is extraocular tumor spread. All of these are high risk factors. Now, this is how eyeballs come to us these days. A chalky white tumor. That's because of the calcification that happens post-therapy. The picture on your right shows those foci of amorphous calcification. Okay, coming to the last common tumor. Middle-aged female, dilated vessels. You see what do you see on the right? What test is this?
A scan, sir. B scan. B scan.
Yes, choroidal melanoma. Very good. Again, you perform a transillumination to locate the tumor. You cut the eyeball, and this is how a tumor looks. See, you see a characteristic mushroom shape appearance over here. Do you appreciate the mushroom shape?
Yes.
Why do you get a mushroom shape in a choroidal melanoma? Anyone? Because the tumor cells proliferate and come out through the what? Brooks membrane, right? Yes or no? And then the tumor again proliferates in the vitreous cavity, pushing the retina, and that's why it gets a mushroom shape. This is how it will look under the microscope. Now, these are the things which are very important when you get a report of choroidal melanoma. Most important is the type of melanoma, whether it's a spindle cell, epithelioid, or a mixed cell. Then you have the involvement of the other structures. And most importantly these days is presence or absence of chromosomal abnormalities that can be detected by karyotyping. Now, which of the chromosomal abnormality is important in a melanoma? Anyone? Have you heard of trisomy 3? Okay, homework for all of you. Okay, now I'm going to show you some pictures. It's spotters, okay? So we are going to quickly go through this. I'm going to show you the pictures. You're going to tell me the diagnosis. But before that, easy spotter.
No.
What is this?
That's my name, Kaustubh.
Coldplay. Coldplay, sir.
Coldplay. Very good. Everyone knows the answer. Very nice. Okay. Now this was a teenage boy who presented with proptosis of the right eye, and the picture on your right is the radiology picture. Just have a look at this picture. Okay. I'm not going to ask you a question yet. Everyone had a look at it? Okay. Now the specimen was sent to me, and this is what it showed. Anyone with a diagnosis? If no one gives me a diagnosis, I'm going to start calling out names.
Lacrimal gland adenoma.
Anyone else? What is this?
The multinucleate giant cells, sir.
Yes, very good. These are multinucleate giant cells. Very nice. So you have multinucleate giant cells over here. Very good. Now what is this? This is necrosis.
Yes,
Yeah?
sir.
So you have multinucleate giant cells, you have necrosis. What is it likely to be? This is a granulomatous inflammation. Yeah? This is how a granuloma looks like.
Yes,
So
sir.
it's a necrotizing granulomatous inflammation. What could it be? Which are the conditions where you see a necrotizing granuloma? Dr. Pragya, you want to answer? Dr. Priyanka? Tuberculosis, right? Yes or no?
Granuloma.
Yes, fungal granuloma, sarcoidosis, all these are conditions where you see necrotizing granulomas. Now, if I want to differentiate between these, is there any stain that I would want to do?
Which stain? Yeah, let them answer. Yeah, because
Come on, this is second year question,
Abash.
second year pathology.
Existence.
No.
Sorry?
No.
This is the HE stain.
Yeah, there is specific stain for tuberculosis, which is that stain.
What is the
Zn
specific
stain.
Zn stain,
Correct,
sir.
ZN. And what do you do for fungi?
Methenamine gomori silver.
Yes, Gomori is methenamine silver stain. And what is it that
GMS.
you do for sarcoidosis? There's no stain for sarcoidosis. Okay. So this is the multinucleate giant cell that she was talking about. And then when I did a staining, this is what I saw. What is the stain? This is Zn stain. And these red bacilli that you see are acid fast bacilli. So it was a case of tuberculosis. Right? Okay. Again, middle-aged female, dilated vessels. You just saw the picture. Now I'm just changing the scan for you. Just have a look at this scan. I'm going to give you 10 seconds.
Choroidal tumor.
Okay, fine, choroidal tumor. Okay, now let's look at this picture. Is it the choroid? Or is it something else?
The ciliary body.
Very good. It's a ciliary body mass. Nice. Now, when the eyeball came to me, this is how the cut section looked like. Can you see this?
Yes.
That's the tumor. Do you still think it is a melanoma? Yes, it could be. It could be a amelanotic melanoma.
Amelanotic tumor.
Okay. Anything else in the ciliary body?
Yeah, you have seen the B scan.
Yes, let's go back if you want. Check this.
See the A scan, corresponding A scan. How is the internal reflectivity? You will see the type of tumor, you can say. You need to correlate both clinical as well as pathological. It's not
Yes.
only pathology, not only clinical.
So here you see you have a mass in the ciliary body. It's a non-pigmented mass. Agree, all of you? Till here? Okay.
Yes.
Now tell
Yes,
me, someone tell me, what is the ciliary body made up of?
the muscles.
What muscles?
Muscles, non-striated muscles, sir.
What is it called? Is it called
Sir,
non-striated or is it called something else? Smooth muscle, right?
smooth muscles, yes.
So what is the tumor that arises from the smooth muscle?
Leiomyoma.
Correct, yes. So it could also be a leiomyoma, and this turned out to be a leiomyoma, right? So apart from melanoma and leiomyoma, is there any other tumor that can be found in the ciliary body?
Epithelial tumor.
Schwannoma. Yes, epithelial tumors also. It's a ciliary body adenoma, it's called. Okay? Adenoma and adenocarcinoma.
One
Okay,
important catch point here is that the tumor brilliantly transilluminates. Okay, that is a catch point of a leiomyoma.
Yes. Yes. Okay, let's take a look at this picture. I'm going to ask you a question after this. 2 questions. Identify the stain. What do you see here? What is the stain?
It's a silver stain, sir.
Yes, silver stain. It's a Gomorrhe's methenamine silver stain, right?
Yes, sir.
And
Yes,
what
sir.
is so? What are these black structures that you see?
Infection. Which infection?
It's fungal hyphae, sir.
Correct. These are fungal hyphae, right?
Yes.
Okay. Okay. What are these? Everyone will answer.
Churros.
Churros. See, everyone answered. Which country did they originate from?
Some European country.
Spain.
Spain,
Okay.
yes. Yes, sir.
What is this?
Waffles.
Which country did they come from?
US.
Belgium.
Sorry.
So Belgian waffles. What is
Yes,
this?
sir. Tiramisu.
Yes. Which country did it come from?
Japan.
Italy.
Italy.
Okay.
Sorry.
So tiramisu means pick me up.
Yes, sir.
Okay. Everyone wants to answer food questions. So let's come back to pathology. A 12-year-old child who presented with eyelid swelling. Now the picture on your right, this one, is what the tumor looked like when it was excised. Spot the diagnosis. Very typical of this tumor. What is the color of the tumor? Come on, tell me at least color to batao.
Greenish.
Yes. So which tumor appears green? Okay, what appears green in color? In nature? Chlorophyll. Isn't it?
Chloroma.
Chloroma. What is chloroma? The other name for chloroma? Granulocytic sarcoma. Right? This is what we saw in the bone marrow. What are these? Blast cells. So AML, case of AML. Okay,
How
now
do
this
I
was a
say
medieval
blast cell? Kaustubh, how
blast
do
cell.
I say
Yes,
blast
sir?
cell? Because they want
Well,
that. How do I
okay.
say
So
blast cell?
blast cells, because they are very large in size. If you see, they have multiple nucleoli over here inside. All these are nucleoli, and
Scanty cytoplasm.
right, so very large cells, high NC ratio, multiple nucleoli,
Scanty cytoplasm.
scanty cytoplasm. Yes. Okay, middle-aged man, eyelid swelling. This is what the CT scan look like, and the picture on your right is the gross specimen. One of you just give me two differential diagnoses. Any two, what do you think it is?
Lacrimal gland.
Lacrimal gland.
Lacrimal gland tumor.
Is it the lacrimal gland?
See.
If I was you, I would rather say epidermoid cyst and dermoid cyst.
Yes.
Would you agree?
Dermoid is likely.
Yes. So what is the difference between dermoid and epidermoid? Epidermoid cyst will have just a lining and keratin in the lumen, whereas dermoid cyst will have dermal adnexae in the wall. Right? See this? These are dermal adnexae. Okay, spotter. Okay, I've asked you the question organism. That means it's some infection.
Yes.
Hydrated cyst, sir. Hydrated cyst.
Publication in this.
Hydrated cyst. And what is the picture on your right?
It's the scolex.
Mark with the arrow. Yes,
It's a
very good. It's a
scolex.
scolex. Very nice.
Hydrated will have multiple.
Okay.
Cysts, yes.
What tumor is this? You want a hint?
Oh.
What am I showing?
Cheese.
Don't look at Jay. Look at what is in his hand. Yes, what cheese?
Swiss cheese.
Swiss cheese. So which tumor has a Swiss cheese appearance? Adenoid cystic carcinoma of the lacrimal gland. And what is it known for? It's known for perineural spread. So you see, this is the nerve over here, right? And you have the tumor around it. So it's very classical. This tumor usually presents with pain. Spotter again.
Papilloma.
Papilloma. Okay, you see papillary structures. I'll give you that. Okay, now I'm going to give you a hint. Look at this picture. What do you see? There's an arrow marked. What is this? What structure am I showing in the arrow?
Lateral rectus muscles.
Yes, lateral rectus. So if the lesion is in the lateral rectus, and this is what you see, what is it?
Which cyst? Cyst. Which cyst? Extraocular muscles associated with some cyst, all right?
Yes. Okay, if I tell you that this person is a meat eater.
No. I said cyst, then they can answer no, easily.
Myocysticercosis.
Yes, cysticercosis. Correct. Very good. Okay, I think we are at the end of the presentation, maybe another couple of slides. This is the orbital tumor. Can any one of you give me two possible diagnoses? Okay, look at this tumor. Benign or malignant? How are the margins of the tumor? Are they irregular? Are they smooth?
Smooth.
They are smooth. So benign tumors are more likely to be smooth. Malignants are more likely to be irregular. Correct? So this is possibly a benign tumor. Now, what do you see over here? You see this part. What do you see over here? Here. What is it?
Nerve.
Yes, no, not optic nerve. It is some nerve. So some tumor which is arising from the nerve. It's a benign tumor.
I don't know.
Sorry? Yes, you said it right. Please speak a little loudly.
Be bold.
Optic nerve glioma.
Glioma is malignant. It will be more irregular. Which are the benign tumors of the nerve?
Schwannoma.
Yes, schwannoma. Which is the other one?
Oligodendromas.
Neurolemoma. No, sorry, not
Neurolemmas.
neurofibroma. Right?
Yes, sir.
Yes. Okay, now the same tumor, when I saw it under the microscope, it was looking like this. What is it then?
The Verroque bodies.
Yes, very good. So which tumor do you see Verroque bodies?
Schwannoma, sir.
Schwannoma, yes. So the arrow on your right, this is where you see the Verroque bodies. And what are these structures? What are these areas where you see
Antony A and Antony
Antony
B.
A and Antony B areas? Very good. Okay, last case, and then we'll wrap up. This was an elderly gentleman who presented with this eyelid lesion. The picture on your right is showing the radiology picture, is the radiology image. Okay, had a look at. Now I'm going to show you a pathology slide. Gross picture. This is how the tumor looked when I cut it. Anyone wants to give a diagnosis? Last case. What do you see over here? See this? What do you see over here? At least tell me that. Forget the diagnosis. What do you see over here?
The xanthelasma.
Yes. Okay. So you see some yellowish discoloration. Agree?
Yes, sir.
Okay. Now what do you see over here? It's a yellowish tumor.
Fat
right?
tissue, sir. Yes.
Correct. It could be fat, something lipidish.
Yes.
Right? Now, this is what I saw under the microscope. What are these cells? See this? Very characteristic cells seen in this condition.
Typical giant
These
cells.
are Teuton giant cells. And the condition is xanthogranuloma. Okay? I think let's stop over here.
Thank you, Dr. Kaustubh. Wonderful presentation for the students, and a few things I like to add. Kaustubh may agree or not agree. Actually, all tissue you remove from the OT need to be biopsied. That's an important thing. But sometimes in research institute, you keep the samples sometimes in minus 80 degrees centigrade. Okay, that's one thing. Again, in your chart, when you showed the what are the form, how you fill up, one important thing is right and left eye. Okay, that's most important for the eyeball. This is a medical legal thing. Signature, date and time. Now, 10% neutral buffer formalin. They ask you how you prepared. For example, 900 ml of distilled water with 100 ml of what you call 37 or 40% of formaldehyde. Then the two chemicals, what he has mentioned, the sulfate, phosphate that you put. And important thing is that map biopsy, what I feel is that numbering of the, because whenever you take the tissue, you have to number those one. For example, 1, 2, 3, 4, 5, 17, 18, that this way, that number should be there. And most important thing is that fixative, particularly if Kaustubh can tell us that for lymphoma specimen, for vitrectomy specimen, it's how it is taken. That's very important. And remember one thing, frozen section, I don't agree that frozen section is for diagnosis. Never diagnose a tissue in a frozen section. A varicose carcinoma can look like a papilloma. Remember that. If you diagnose with the help of a frozen section, permanent section is better to diagnosis. And as Kaustubh is sebaceous gland carcinoma. One important, the clinical aspect is also important. The large tumor, more than 10 mm, And 6 month duration, more than 6 month duration, again is a worse prognostic case. And in examination, for DNB examination, sometimes if eyeball is showed to you, they ask you site determination of the eyeball. That's very important. Okay, how you site determination, do the site determination. And when Kostov asked this question, what you cut first in the eyeball? See, again, in choroidal melanoma, probably Kostov have different cross photographs. There is something we have to mark in the by surgeon, the vortex vein exit with a blue tissue tech pen, because that vortex vein also we dissect sometimes in choroidal melanoma for vortex vein invasion. Okay, and another OSCE question that came with Jaden stain is that what are the other stain you do for a tuberculosis? Okay, you have a quinoin stain which is called a cold Jaden stain. Okay, and oramine rhodamine stain or acridine orange can pick up acid fast bacilli. And leiomyoma, wonderful case, Kostov has shown where immunohistochemistry is required. And thing is that very nice way Kostov has shown his cases. Any comment can we answer from the student? If they have any query, they can ask Kostov or myself. Thank you very much.
The retinoblastoma rosettis and all were not dealt with in greater detail.
Yes, sir. Flexner Wintersteiner in 1886, they have described a rosette which is called Flexner Wintersteiner. Flexner was a pathologist and Wintersteiner was a ophthalmologist. Now these are actually round cells which are there in a concentric way around a central clear lumen. Okay, whereas in Homer Wright rosette, Homer Wright was a famous pathologist from US again. He gave a Homer Wright rosette which do not have a clear lumen. It has a neurofibril tangle inside. And we have described, myself has described one other rosette, whereas these are larger for conventional flexor intestinal rosette, which is a larger lumen, and within the lumen the cells are there. So characteristically, this is a third different rosette that we have discussed. So these are the
What is the name of third this thing, Dipankar? Did you name anything?
No, I did not name it. It depends on peer to give a name. Okay, it's peers to give a name. Rather, I have published that and discovered that rosette.
Okay.
And there is something called a fluorettes. Now, examiner can ask you, examine, these are much more for differentiation. And fluorettes, you see what the name comes from is the scout symbol where the fluorettes is actually derived. And these are actually differentiated cones. Okay, and they are much more prevalent in a benign counterpart of retinoblastoma called a retinoma or retinocytoma, where fluorettes are being found.
Right. Students, do you want to ask any questions to these two giants? The pathology giants, actually, Dipankar and Kostov. We can ask many questions actually to them. This is a great opportunity.
Dr. Kalpita, your comments? She's a panelist. Dr. Kalpita, are you there?
Yes, sir, I'm there.
Welcome.
Dr. Kostov, it was a very wonderful talk. Actually, I also got to know a lot of new things in this presentation. I would request, sir, if you can add something about the vitreous biopsy specimens for lymphoma. So how the samples to be taken, how to process, what are markers to be seen in case of a vitreous biopsy in a suspected case.
Sample collection we have covered in the last presentation by Dr. Santosh Hanover. The process, Kaustubh, I think you
Yes.
need to add something. The type of
So,
cells mainly.
so the sample has to be sent to the lab as early as possible. Now, what ideally needs to be done, I think Dr. Dipankar will maybe
Kaustubh,
want to
probably
comment on
after getting the sample, what will you do? And with stains, how will you differentiate? That would be
Okay.
more interesting for us.
So what we first do is we make a cell block out of it. Because in a case of suspected lymphoma, we would want to do immunohistochemistry. And when we do IHC, we usually run a panel of markers. So that's when we make a cell block and then we can make a sections out of it, it becomes easier to do those run those antibody panels. Now, most lymphomas, primary vitreoretinal lymphomas, are B cell type, and they are usually large B cell type. So we do a CD3, CD20, CD45 to confirm whether they are T cell, B cell, and then there are some cases where we would probably want to get a flow cytometry done. Sometimes we might want to get a FISH done. So we usually keep some sample aside fresh, like Dr. Dipankar said, we would probably like to preserve it, and the rest of it we centrifuge it and make cell blocks out of it. And this stays with us for a lifelong.
No, but the lymphoma cells, if it made into cell blocks, after that also, because we know the lymphoma cells are very fragile and they get lysed very soon. So
No. Once you make a cell block, once a preservative is added and once you centrifuge and make a cell block, they stay permanently.
okay.
Nothing happens.
And in lymphoma, another challenge what we face is that because the samples are sometimes the number of cells are very less.
Yes.
So
Yes.
how do you deal with that challenge?
That's a very tricky question to answer. So
can I add, Kalpita? Can I add something?
Yes, sir.
First of all, first issue is that how we fixate it, because you are getting from the cassette the samples and some samples from the vitrectomy thing. Now, initially, when in US and in European state, they have two methods or two fixative. One is called a Hope fixative, Sarah Copeland and Cytolite. Now, in Kaustubh article, you see in vitreoretinal lymphoma, he has given a proportionate way of ethanol, methanol, and propanol. Maybe that is also useful, but most important thing, as Kaustubh said, after rapid transportation to the lab. Now, after rapid transportation of the lab, one thing is that if it is around, say, 4 or 5 ml, 1 ml you can see directly, okay? Directly whether you are seeing. Another thing is that to do an HND stain also in the cytology ways, okay? What is important is that sometimes in the necrotic background, you can pick up the lymphoma cells, okay? And I have personally very interesting and looking those things, whether myself without any stain, I can pick up lymphoma cell. Thing is that next 50 or 100 years, imaging will be a very, very challenging thing. Whatever thing we are putting in the slide will be represented in a slit lamp view to see the cells. Okay, next 50 to 100 years, they will come how to pick up the cell directly under a slit lamp view and differentiate from inflammatory cells and lymphoma cells and leukemia cells, or leukemia and the metastatic cells. Okay, this one day it will come. I am very much sure about it, very much optimistic. Now, thing is that now there is, apart from it, there are other things for diagnosis. For example, you can take those as Kaustubh told, various immunochemistry. I have a different way because these are B-cell lymphoma. For me, CD20 need to be positive rather than CD3 should be positive. And kappa lambda, either of them can be positive. And important thing is that whether CD79A or other marker is positive. As CD45, Kostov has said, is a LCA. Suppose it's a leukemia or other thing, CD45 will pick it up. Now, thing is that there are other important things. For example, the gene expression, MID88 gene expression by PCR method can give a better yield. Okay, so there are constellation of things, but I'm very optimistic that one day, we can visualize lymphoma cells by our Sitley method. That will reduce. Nowadays, the problem is that most important problem is that we are unable to differentiate in the live condition between a lymphoma cells, inflammatory cell, granulomatous versus non-granulomatous. Plus, what is important is that the metastatic cells. Okay, this will be one day solved by live imaging.
Dipankar, you said cassette fluid, but by the
Yes,
time
sir.
you collect in cassette fluid, all the lymphoma cells will lyse. So it's better to take the fresh sample with low cut rate and high aspiration so that the yield can be better.
Yeah, yield can be cut. Yeah, but thing is that if we have a large volume of cells, what is it? Then another method I have not told you is that we can cytospin the thing by 5,000 revolution. We can cytospin the thing and make those concentrated way from the bottom of the elucate thing. We can pick up those concentrated cells.
Right. Any other questions? So any PGs, you have any more doubts?
Yes, PG interaction should be there. Hello. Dr. Pragya? Smruti, do you have any questions or you want to add something?
You want to know anything more also, it's fine. You need not ask questions only.
Yeah.
Doubts also you
They're
can
having
ask.
waffles and churros now.
Hmm?
They're having waffles and churros.
They are excellent in that.
Sir, I wanted to know a little more about the map biopsy.
Yes,
Sir,
doctor.
what should be the correct procedure, sir? I mean, as soon as we excise the sample from each area, as we have drawn in the diagram, after that, sir, as in how exactly should we place it? Should we place it directly on the tissue paper?
Yes,
Like, should
place
it
it
be
direct, not
any
tissue paper. You have to place it on a Whatman filter paper number 43.
number 43, sir?
Yes, and you first draw a diagram. You mark the points like Dr. Dipankar said. You have to label them from 1 to 10 or 1 to 17, whatever, so that it will be easier for you to identify that number 1 is from so and so place, number 2 is from so and so place on the ocular surface. You draw a diagram.
Okay.
You place that particular tissue right on the filter paper. You allow the tissue to dry, and then you pick up the whole filter paper sheet and put it in format. That way, the tissue will not come off the filter paper.
Okay, so after the paper has dried, I mean the samples on the paper have dried, after that we can place it in
Then you put
formalin
it in,
solution.
take a polythene bag, add formalin fixative to it, and then you put the whole filter paper inside.
Okay, sir.
But if you are, let's say, your pathologist is in a different city, then you can have small tubes, which are called Eppendorf tubes. You put each sample separately in a separate Eppendorf tube and transfer those tubes via courier.
Okay, sir. Thank you, sir.
You're welcome.
I think there's no discussion will close it.
Okay.
No? So, once again, I thank everybody for joining this program. I thank Dr. Kostov. Give us a vivid picture of a lot of pathologies related to ocular oncology. And I think the students have learned a lot today. I thank you, Dr. Kostov. And Dr. Dipankar, adding some things to the what Dr. Kostov said, and also Dr. Kalpita participating in the discussion. Thank you all. So with these few words, I thank everybody joining this program. and look forward to meet once again the next fortnight. Thank you. Good night.
Good night, sir.